Did you know that bowel obstruction can be life-threatening within hours? Let's find out why medical students should understand this disease process and how it could be life-saving. When you talk about bowel obstruction, you have to actually paint a picture in your mind on how it would look like. It would be someone with nausea and vomiting, someone with abdominal distension, plus minus pain. And this is the thing that may resemble other disease processes like an ileus or a delay in bowel function. However, there is an urgency to bowel obstruction when there is a mechanical cause that needs to be treated surgically. So how do we actually go about it in understanding how to triage which patient needs surgery? Because the most important thing is who needs an operation and when do they need the operation. Those are the top two things that you have to understand. First, who? Well, you have to triage the patient as emergent, urgent, and the question would be, is there an elective aspect? For emergent, these are the patients who are going to be unstable. They're hypotensive, tachycardic, they could have fever if they have signs of peritonitis or perforation as a concern. Other things are people with a mechanical feature that is a incarcerated or strangulated hernia that is causing an obstruction, or if there is a mass. There's also a difference between a small bowel obstruction and a large bowel obstruction. The most important differentiator is if you have a large bowel obstruction, you have an ileocecal valve that may act as a one-way valve if it's competent, and that forms a closed loop obstruction. So basically, at one point in time, you have a distal obstruction and a proximal obstruction that allows things to pass through, making the obstruction worse. This is a surgical emergency because it is higher likelihood to perforate. Once you've differentiated this subset of population from the other patients, then you could decide whether the patient that you are going to treat non-operatively, which we'll discuss in a few, can actually succeed, or will they need urgent surgery? Who are they? Well, if you treat somebody non-operatively, this will actually require bowel rest, NG tube decompression, and a small bowel follow-through to prove that either the bowel obstruction in the small bowel has resolved, or if it's persistent with no progression of contrast into the colon. So the three things that will require an operation if they don't fit the emergent criteria are the people who fail non-operative management, those with recurrent disease process, meaning they have come back multiple times with multiple episodes of bowel obstruction, and lastly, those people who have clinical changes who are previously stable and now become unstable or convert to somebody who has signs of sepsis and peritonitis. As mentioned, the things that we have to do is, number one, protect the airway. If somebody's vomiting, you want to avoid them aspirating, so there's nothing to eat. Decompression of the stomach with at least a 16 French NG tube, and this would be connected to a low wall suction. Most of the time we prefer intermittent, but the biggest thing is it's actually confirmed that placement is in the proper position and that it is actually working. Troubleshooting an NG tube, ensuring that there is fluid being suctioned, is important. Making sure that the sump port is not blocked is another thing, and then occasionally checking on it to ensure patency is of paramount importance. Other things include IV fluids, how much you're going to be given. Are you going to start resuscitative fluids? And what type of fluids are you choosing? And this could be based on their comorbidities and electrolytes. You could check out the previous video on IV fluids to check on which fluids to give. And measuring their I's and O's. Why is that important? Well, somebody's not eating, and then you have fluids that you're giving, and they could be dehydrated because fluids pumped out of their stomach, which actually has electrolytes, mainly potassium and chloride. So you have to monitor all of this. And so the NG tube output is one of the things we do measure as well as their clinical findings and exam. Are they distended? And do they have bowel function? Particularly, have they actually passed gas? Once you've opted to perform the non-operative route, then you can allow decompression of at least 2 hours for the patient and then provide a soluble contrast study to check if it will actually reach the colon. We perform this with 90 ml of Gastrografin, which is inserted into the NG tube, and then it is clamped. The head of bed should be elevated to at least 30 degrees at all times to prevent aspiration. The NG tube should be placed to gravity for at least an hour to allow antegrade contrast passage. If at any point the patients feel nauseous or has worsening abdominal pain, you should actually replace the NG tube to low wall suction. If the contrast is not propagated to the colon in 24 hours and reach the cecum, then that is something that you should be concerned about if an operative intervention is indicated. Once you've stabilized the patient and are monitoring them, the other things that you have to keep in mind are their previous surgeries, their medical comorbidities. When you do your physical examination, ensure that they don't have concerning features of peritonitis, that what type of scars they have. Do they have a midline, a transverse, laparoscopic port sites? These are all parts of your decision making that you have to consider. Another important aspect is ensuring that there are no hernias causing the obstruction, because if the hernias is incarcerated and it is non-reducible, then this becomes a surgical emergency as mentioned. For laboratory testing, we opt to perform a CBC and a BMP to monitor your electrolytes. For imaging, we would start with a CAT scan with IV contrast. From there, we can see if there are going to be concerning signs of the features I mentioned above based on the CT findings. What are these? Well, if you have a bowel obstruction, is there going to be a transition point? Is there going to be signs of a closed loop obstruction? And are there hernias causing the obstruction that makes it a concern for a surgical emergency? There's also other signs which are concerning, and this include signs of ischemia that may force us to operate emergently. So now that we've actually started with our workup about triaging the patient, starting with, is the patient stable, unstable? Do they have signs of peritonitis or impending perforation? Or do they have a mechanical obstruction that we need to address early? And then we look at the next set are the urgent, no progression, recurrence, and those who actually get worse. For those people we are treating non-operatively, then we can follow who actually progresses, and then we can remove the NG tube and start their diet if they're successful. Or if they don't, then we get to the part that they go back to urgent, that we need to do an operation. And the operation mainly has to focus on resolving the obstruction. And this would require either lysis of adhesions or a bowel resection plus minus an ostomy formation or an anastomosis, depending on the patient's status and the location of the obstruction. If a hernia is involved, you also have to consider how you're going to fix the hernia in what type of setting. Is it going to be a clean case, a clean contaminated, and is the patient optimized to decrease the risk of recurrence? So what are the numbers and the chances of you actually getting another obstruction? Because if you think about it, when you operate, you get scar tissue, and we're talking about adhesive disease. If you get scar tissue, then you operate to break down the scar tissue, then you'll develop new scar tissue. Well, why break it down? Well, difference is you have to address the current situation and try to prevent the future one. But the more urgent situation is if a scar tissue is causing an obstruction, then you have to relieve it, or it will progress to perforation and may actually kill the patient. And so the numbers actually are the risk of recurrence with non-operative management is 12% in 1 year, with a 20% risk of recurrence in 5 years. when you actually have an operation, this decreases to 8% in 1 year to 16% in 5 years. And so there's a 4% difference, but there's still overall a risk of recurrence that is quite notable in that span amount of time. 20 to 30% of adhesive bowel obstructions will require an operation at some point in time. So now that we've actually focused on what we're going to do with regards to the surgery and how to relieve the obstruction, how are we going to do it? You've got options on minimally invasive surgery or open surgery. The difference would be you would have less likelihood of scarring if you do MIS versus if you do open, because then you'll actually have a fascial closure and a lot more manipulation and a lot more risk of adhesion formation. But you have to take into consideration who would most likely be successful candidate when you're doing it laparoscopic, because that can be a disaster when you perforate the bowel in a setting like this. And so prognostic indicators include people who have less than 2 laparotomies, people who only had an appendectomy as their primary operation, people who had no previous median laparotomy incision, a single adhesive band, which sometimes can be seen on a CAT scan as an isolated area. It's basically more difficult on patients with previous radiation therapy. Now that we've actually summarized it, we can properly triage the patient, manage it urgently, emergently, and non-operatively, and then monitor our success of non-operative treatment to ensure we actually filter and catch those who would actually not be successful and need operative intervention. And for operative intervention, we've detailed the steps which we need to achieve to address our primary focus, which is to relieve the obstruction. If you guys like the video, please comment down in the chat. If you have any questions, click the like and subscribe button, and check out the video above for more learning. And I'll see you guys next time.